we'll be seeing about loading and occlusal concepts in implants. What is a dental implant? It is a prosthetic device made of alloplastic material implanted into an oral tissue beneath the mucosal or the periosteal layer and or within the bone to provide retention and support for a fixed or a removable dental prosthesis. So coming to the introduction, the tactile sensitivity and the functional regulation of jaw movements are completely different between the implant and the natural tooth. The occlusal loadings will be 3 times more higher on a removable dental prosthesis, whereas it's going to be 9 times higher on a fixed dental prosthesis. Let's start with few differences between the natural tooth and the implant biomechanics. The natural tooth has the periodontal ligament that surrounds it, which will act as a shock absorber and helps in the distribution of force along the entire tooth surface. But the absence of the period or the periodontal ligament in the implant leads to a direct contact of the bone and the implant, which will concentrate all the force primarily to the crest of the ridge. The presence of the sensory nerve complex in and around the tooth, and there is not going to be any nerves present around the implant. The occlusal trauma will induce hyperemia and leads to cold sensitivity, whereas there is not going to be any precursor sign of slight occlusal trauma in implants. The occlusal material and for the natural tooth is going to be the enamel, and the cortical bone and the bone surrounding bone is going to be cortical. Whereas for an implant crown, it's either going to be a porcelain crown or the metal crown, and the surrounding bone is going to be trabecular. What is implant protected occlusion? It refers to an occlusal scheme that is often uniquely specific to the restoration of the endosteal implant prosthesis. How should an occlusal scheme be designed for an implant prosthesis? It should be such that the forces are directed along the long axis of the implant and minimizing the lateral forces. If the lateral forces are comprehended, it should be placed as anteriorly as possible. So if it is impossible to neglect any lateral forces, we can anteriorly distribute them over as many teeth or implants as possible. These are the certain factors which influence the implant protected occlusion. So starting with premature contact or interference. Implant has no periodontal ligament. So concerns arise about the potential of non-mobile implants to bear the total load of the prosthesis when joined to the mobile natural teeth. There will be a sudden initial tooth movement up to 8 to 28 microns in vertical direction when 3 to 5 lb of load is applied. Implant doesn't have any such initial sudden movements. There can be movement of up to 3 to 5 microns after bone causes it to move. What about the surface area? When implants of decreased surface area are subject to increased loads, the stress can be minimized by placing either an additional implants or implant crowns can be splintered together, or the wiser choice of wider implants could be used. When forces are increased in magnitude or direction or duration, additional procedures like ridge augmentation or reduced crown height or increase implant width and increase in number of implants can be advised. Mutually protected articulation. What is it? It is an occlusal scheme in which the posterior teeth is going to prevent excessive contact of the anterior teeth in maximum intercuspation, and the anterior teeth will disengage the posterior teeth in all mandibular excursive movements. The anterior guidance of an implant prosthesis with anterior implants should be as shallow as practical. The steeper the guidance, the greater is going to be the force on the anterior implants. How should be the implant body oriented, and what is going to be the influence of the load direction on implants? Implants are designed for long axis loading. An axial load over the long axis of the implant body will generate a greater proportion of compressive stress rather than the tension or the shear stress. As you can see in the first image, the forces are generally to be directed perpendicular to the implant body and not on the lateral loading. So the lateral loading will cause more tension, that is the shear stress around the crest of the ridge especially. So the cortical bones will be generally strongest during compressive loading and 30% weaker in tension forces. So the implant protected occlusion will eliminate shear loading. The greater the angle load will cause greater shear loading in the crestal area, which will ultimately decrease the ultimate strength. Natural teeth usually have a 30-degree cuspal angulation. Cuspal angles will modify the direction of force to the implant, resulting in angle load to the crestal bone. So for an implant crown, the ideal is to create a flat surface by increasing the width of the central groove to 2 to 3 mm and recontour the opposing cusp also. Cantilevers and implant productive occlusion. Generally, the cantilevers will increase the amount of stress to the implant. The magnitude of loads sustained by the implants is going to be proportional to the length of the cantilevers, and that will also vary according to the number, the spacing, and the location of the implant. Crown height and implant productive occlusion. The crown height will also influence the amount of occlusal loading on the implant. The implant crown height is often greater than the original natural anatomical crown. Crown height with a lateral load will act as a vertical cantilever and also act as a magnifier of stress at the implant to the bone interface. The greater the crown height, the greater the resulting crestal moment with any lateral component of force. Occlusal contact positions. The number of occlusal contact in an occlusal scheme varies. For example, P.K. Thomas' occlusal theory suggests that there should be a tripod contact on each cusp, that is the functional or the occluding cusp, on each marginal ridge and on the central fossa. The central fossa is the logical primary occlusal contact position. It should be 2 to 3 mm wide in the posterior tooth and parallel to the occlusal plane. Secondary occlusal contacts within 1 mm should be within 1 mm of the periphery of the implant. What is the use of giving a narrow occlusal table? There can be a less force during mastication, but this will require a daily home care and also reduces the risk of porcelain fractures. Restorations mimicking the occlusal anatomy of natural teeth often result in offset loading, which leads to an increased stress and a complicated home care and increased risk of porcelain fracture. In non-aesthetic regions of the mouth, the occlusal table should be reduced in width compared with natural teeth. So we have seen the occlusal schemes so far and the and we can herewith see the loading protocols. The evolution of the concept of implant loading, the surgical and prosthetic protocols were first developed and reported by Brenmark et al. According to him, the 3 months osseointegration period for the mandible and 6 months for osseointegration period of maxilla is advised. So once the tooth has been extracted, he's according to Brenmark, he suggests to wait for 3 to 6 months until the first stage of surgery or the implant placement. And once that is done, 4 to 6 months period of osseointegration is advised, then to be followed with stage 2 surgery. So the bone quality, the bone density, as we know, D1, D2, D3, and D4 bone. The D1 bone is dense cortical bone, which is usually present in the lower anterior mandibular region, most commonly, and D2 and D3 bone are commonly present in the posterior mandible and in the anterior maxilla. D3 bone, being the fine trabecular bone, is generally seen in the posterior maxilla. So the types of occlusal loading protocols would be progressive loading, non-submerged single stage, immediate functional loading, early loading, immediate non-functional loading, delayed loading, and anticipated loading. What is progressive loading? In this, the provisional prosthesis will be brought into occlusion progressively depending upon the bone density. Non-submerged single stage, it's going to be for the non-submerged implants which will flush with 1 to 2 mm of the gingival levels. Immediate functional loading will involve giving the temporary restoration on the same day of surgery, which has to be brought into occlusion. And then what is the immediate non-functional loading? The temporary restoration will be fitted on the same day during the surgery, but occlusion will not be given. Early loading, the final crowns will be given within 3 weeks from the surgery in occlusion. Delayed loading, implants will be subjected to loading after more than 6 weeks post-surgery. Anticipated loading involves provisional prosthesis being fitted after about 2 months after surgery. So this is a generalized example of how the implant surgery goes on. Once the implant has been placed and healing after 5 to 6 months, the status of the implants will be assessed using X-rays, and the stage 2 will involve uncovering of the periosteal flap and recovering the cover screws. And once it has been identified, the indirect impressions will be done using the transfer copings and the impressions made with the silicone material. And once the impression has been made, the implant will be closed with the firm mucosal extensions or the healing caps. So the impression will be poured and the mounted models will be articulated, followed with metal train, and either provisional or the final prosthesis will be placed. So to conclude, loading within proper time frame should be considered a routine for all clinical situations, either in edentulous or partially edentulous conditions, for long-term success of the restoration. Thank you.